So we have another duo of speakers. If you'll allow me, I'll take a moment to introduce them both, and then they can get their presentation as well. So Dr. Roonprapunt is assistant professor of neurosurgery at Mount Sinai West. He also did his undergraduate work at Cornell, not at the same time, I think, Dr. Natick. MD, PhD at NYU, followed by neurosurgery residency at Albert Einstein, and an orthopedic spine fellowship at Beth Israel. And then Dr. Caton, who is also an assistant professor of neurosurgery and neurointerventional neuroradiology in the Cerebrovascular Center. Spends a lot of time at South Nassau, but also we see him around Manhattan as well. Did his undergraduate work at UT Austin, MD at Columbia, and then his radiology residency at Brigham and Women's before finishing his neuroradiology training at UCSF. So I will turn the screen over to you guys.
Peter, I wanted to thank you for putting together this grand rounds and going along with this sort of thematic group of lectures. And I think this is all great. I always love hearing Dr. Natish's lectures. I learned so much, and I wanted to thank you. And Mike Hurley's talk was a great prelude and sets me up for my talk. Do you guys see the slides?
No.
Yes? Okay, great. So, title of my talk is going to be exploring Syringomyelia. I chose the words exploring to sort of reflect the fact that the two cases that we're going to go through, there's a case report and a case series, sort of involve some degree of research and perhaps some investigation. So the talk is going to be divided into two different sections. The first half is going to deal with a case report that we're trying to put together involving the treatment of recurrent syringomyelia with an endovascular procedure. Travis Caton in our department was instrumental in helping with this case. He's actually on vacation, but has graciously offered to talk. And as long as we can get a good Zoom link, and I think he's on board here, it'll be great to hear from him. The second half of the talk is going to be just reviewing a case series to highlight a research project that involved looking at a series of thoracic dorsal arachnoid webs, which can cause syringomyelia. Here we looked at a large series of cases found at Sinai over a 10-year period. So I have no financial disclosures. As you know, the mission of the department is to provide excellent care for our neurosurgery patients. What I'm amazed by is that the two entities that I will talk about today was not fully appreciated when I was training as a resident. And this is important for the residents because the current body of knowledge that you acquire at this particular time is going to obviously change and evolve. Another example for me was the advent of middle meningeal artery embolizations for treatment of subdural hematomas, which is something that I did not know of as a resident. So let's get into syringomyelia. The early anatomists, hundreds of years ago, had recognized within certain pathologic spinal cord specimens that there were these fluid-filled cavities inside the spinal cord. But it wasn't until 1827 when Charles Prosper Olivier coined a phrase syringomyelia. And he took these, he put together two Greek words, syrinx coming from the Greek, meaning tube, and myelio referring to spinal marrow. And in part, I think he got these terms from Greek mythology. We know in the left lower panel that syrinx was a beautiful nymph who was being pursued by Pan, who is the Greek god of the wilderness. And Syrinx was running away from Pan, and she reached out to her fellow river nymphs to try to help her. The river nymphs changed her into a hollow reed by the river. Pan, who was very frustrated by this, had his breath brush by the reeds, and you could hear a beautiful sound coming from those reeds. So Pan took the reeds and ultimately put the reeds together to form this tubular instrument that you see in the right-hand corner that we call a syrinx, also called the pipes of Pan. That's a little bit of history. Let's go into, sometimes the word syringomyelia can have some confusing nomenclature or terminology. You may read about hydromyelia, syringomyelia, or even syringohydromyelia. And sometimes these terms are used interchangeably. Here in the left panel, we could see hydromyelia refers to sort of a smaller benign remnant of the central canal. This fluid collection is typically just on cross-sectional view. It's rounded, it's in the center of the cord. If you look on sagittal view, it can be fusiform or spindle shape. Importantly, the hydromyelia doesn't expand the cord, and essentially it's a benign anatomic variant that's not a surgical problem. And that's to be distinguished with the right-sided panels here, which reveals a syrinx, which is a distended cavity. It's often somewhat eccentric, it could be irregular, and when you measure these, they tend to be greater than 5 millimeter in diameter. Sometimes these cavities can enlarge with gadolinium, enhance rather with gadolinium. So patients develop symptoms when these fluid-filled cavities can enlarge. Sometimes they dissect their way through the spinal parenchyma, and the patient's neurologic symptoms are oftentimes related to what is being disrupted. Is it the gray matter or the white matter? Now, Mike Curley had a nice introduction to Chiari, but if we look at syringomyelia, it's rare. And the National Organization of Rare Diseases estimates that perhaps there's about 8.4 cases per 100,000 per year. These cases of syringomyelia are usually diagnosed in patients between the ages of 20 to 50. But there are many different causes to syringomyelia, and Dr. Bolognese gave a nice talk about a primer for Chiari malformation just a few weeks ago, and Mike Curley had this nice background for us. And you could see that in terms of causes of syringomyelia, Chiari malformation is the most common type, about 60%. The other cases can be considered primary syringomyelia, or somewhat arising from a pathology not at the level of the foramen magnum, but more at the level of the spinal level, and this can be a result of an infection or hemorrhage or tumors that can cause either damage to the spinal parenchyma or a underlying tethering of the cord, which leads to this pathologic cavity within the cord. So let's get on to our case. This is a 59-year-old gentleman. He came to me with chronic intermittent headaches. These headaches characteristically worsened, he had mentioned, after coughing or laughing. 1 year prior to his seeing me, he reported a really significant fall in his garage. He fell on his side, and after that fall, he started to develop worsening headaches more frequent. He was getting pain into the right side of his body, neck, shoulder, and into the lower extremity. He was having difficulty with fine motor movements in his hands, and he was unstable in terms of his gait. Interestingly, his past medical history, he had described that he was diagnosed with the seizure disorder about 30 years ago, for which a neurologist gave him phenobarb for 1 year, and then the neurologist decided to discontinue it, and the seizures never came back. On exam, he was notable to have numbness across the V2, V3 distribution. He had nystagmus on right lateral gaze, and he had decreased sensation along the right arm, and he was difficulty with tandem gait. Here on the lower panel, you could see he has a Chiari-1 malformation. There is tonsillar ectopia below the level of the foramen magnum, which was measured to be about 1.8 centimeters below the foramen magnum. Here on the, you could see some signs of a cervical syrinx in the middle panel. The T2 image shows that the syrinx extends from C2 to C7. On axial view, you could see the syrinx is somewhat eccentric to the right side. Because of that, he had gotten a gadolinium MRI, which didn't show any evidence of enhancement. Because of his neurologic symptoms, I recommended surgery for him, which involved a posterior fossa decompression, involving a variety of procedures, including suboccipital craniectomy, a C1 laminectomy, and this is in an effort, as we had heard before, is to create space, to make more space at the level of the foramen magnum, because as we've heard that the Chiari-1 malformation is a defect in the size of the posterior cranial fossa. Sometimes I like to tell my patients they're a little too smart for their own good. In other words, they have too much brain matter for the skull that contains their brain. So the brain herniates down into the spinal compartment. So that involves sort of the extradural decompression, but in this patient, because there is obstruction likely at the flow, at the level of the arachnoid causing the syrinx, we made a decision to go ahead to do a duroplasty as well as something called tonsillar reduction, which involves bipole coagulating the tonsils to make them shrink in size. So you can see here the pre-op scan, and the patient did well after surgery. He tolerated the procedure well and actually was discharged home on post-op day 2. When we fast forward to 3 months later, he came in for follow-up, evaluation. He reported that his headaches had improved, but there was still some ongoing paresthesias that he had into his upper extremity. I had gotten a follow-up MRI, and you could see that the size of the syrinx, yes, had improved compared to the pre-op. And there was some improved space at the level of the foramen magnum. I followed up. I had him come to see me again, and because typically at 3 months, I usually see a somewhat greater improvement in the syrinx. So I wanted to have a good follow-up with him. At 8 months, he was describing worsening paresthesias and some pain along his neck. And so we re-imaged him, and you could see there was a significant enlargement of the syrinx. And now it was extending into the thoracic spine to about T3. In evaluating this and reviewing it with others, I felt it was appropriate to take him back in order to potentially enlarge the craniectomy to check to see if he had developed any other adhesions that may be obstructing the flow of the CSF at the level of the foramen magnum. So we took him back to the OR. He had a posterior fossa revision, which involved removal of the original pericranial duroplasty, did lysis of adhesions, and then we put in an alloderm patch. And you could see here that there is significant enlargement. Scanned him at 2 weeks afterwards, and if you compare the pre-op to the post-revision, there is improvement in CSF spaces, and the syrinx has gotten smaller. And he was feeling better. Now, in a relatively short period of time, let's say 2 months later, he started to report a recurrence in his symptoms again. And so I rescanned him, and there we see it again, a recurrent in the syrinx. And so this was quite troubling. I sent him for a MRI with gadolinium, in part to try to see if there was perhaps an infectious reason for this to occur. But what came up on the radiologist's report was that there were findings suggestive of the condition called spontaneous intracranial hypotension. And so in the MRI here on the left side, you could see with the gadolinium, there's smooth, diffuse dural enhancement. On the right side, you could see there's central herniation of the brain, cerebellar tonsillar ectopia, other findings, pituitary gland enlargement with some suprasellar extension. So spontaneous intracranial hypotension is a condition that is actually being recognized with increasing frequency and is somewhat underdiagnosed. The intracranial hypotension is related to a CSF leak that is occurring at the spinal level. These patients typically come in, and it's estimated that about 90% of the patients have a orthostatic or postural headache. In other words, it's a headache that is brought on by being upright and improves after the headache, after the patient lies down. Now, this isn't like a typical headache where you go and you take a Tylenol and the pain goes away. This is like a very debilitating headache that really affects these patients. When the condition is quite severe, they can have some other neurologic problems, including gait disturbance, cognitive dysfunction, hearing loss, and in very rare circumstances, you could see this spontaneous intracranial hypotension as a cause of initial presentation of being in coma even. There are a variety of groups throughout the country of note, the Mayo Group and Sinai, who have created spinal leak centers, if you will, and have been studying this problem, and they have done some significant epidemiologic work that estimates that this condition of SIH occurs approximately 3 to 5 cases per 100,000 per year. And what was of interest is that even though these are somewhat diverse populations, that they arrived at a number that was somewhat similar. The patients tend to be occurring from 30 to 50 years old when they present, and there is a predilection for women, and perhaps this is in keeping with a connection with connective tissue disorders, for example. So just to review, within the our cerebral spinal fluid system, there is measured oftentimes about 150 milliliters of CSF. That's in both compartments. And what we know is that the CSF is produced by the choroid plexus, and it's a rather dynamic system. In fact, the choroid plexus makes about 300 to 450 milliliters of CSF. So even though there's such a high production rate, there's a smaller circulating volume. And so there's a great deal of reabsorption of this volume. And so it is a dynamic system of fluid creation and then fluid reabsorption. So what are some common radiologic findings that we see in spontaneous intracranial hypotension? So you know that with the fluid draining through the spinal compartment, that the ventricles can collapse. That's in the middle panel. But interestingly, some of the other radiologic findings can be explained through the Monro-Kelly doctrine. So as we remember, the Monro-Kelly doctrine states that the volume of the brain and the volume of the CSF and the volume of the blood put together is all a fixed or constant number inside, and this has to be an intact skull. And what this Monro-Kelly hypothesis has shown that whenever there is a decrease or an increase, let's say a decrease in CSF, there's going to be a reciprocal increase in another component in this system. And so in SIH, when we have a decrease in the CSF, we oftentimes see a reciprocal increase in the blood flow through the venous system because, in large part, because the venous system has a greater compliance. And so if you look at the left, the far left and far right, well, let's go with the right side, you can see there's engorgement of the sinuses, and on the left side, you get, whenever you apply gadolinium, you get diffuse pachymeningeal enhancement. Now, there are other interesting findings that can occur with spontaneous intracranial hypotension that can look like other conditions that we treat. That's why I use the term mimicry here. So with excessive drainage, sometimes these patients will develop bilateral hygromas or subdural hematomas. There are, reports in the literature of patients getting sepsis or even burr holes, and unfortunately, the subdurals come back, and that's in large part because the mechanism wasn't adequately treated. In the middle panel, oftentimes you'll see pituitary engorgement or hyperemia, and as a result, with the enlargement of the pituitary, it can be draped over or cause mass effect upon the optic apparatus. And then there are some case reports of patients undergoing pituitary surgery for this. Finally, on the left side, you could see that patients can get tonsillar ectopia, a so-called acquired Chiari. With the loss of CSF, you'll get flattening of the pons, or you can have effacement of the suprasellar cistern. So these are all important MR findings. CSF leaks in general have been found to be difficult to diagnose, and so a scoring system was developed, and the one that's most commonly used is called the Bern score. This Bern score was named after Bern, Switzerland, where researchers had studied the different MRI findings, and they tried to correlate which findings had a higher probability of finding a CSF leak in a patient. So the score ranges from 0 to 9. The higher the scores, the higher the probability that the patient has some underlying CSF leak. They're both qualitative and quantitative measures within this scoring system. And the system is actually broken up into some radiologic findings that get a higher score. They're called major findings, and some other findings that get a lower score or minor. So by using this Bern score, it can serve as a way to figure out whether or not we should continue to pursue further imaging, in particular invasive imaging, to try to really look for the signs of the CSF leak. So we applied the burn score to the patient, and he had a very high burn score, an 8 out of 9, which suggests a very high probability that there will be a CSF leak. So these CSF leaks have been classified, and this is pictures from a review article by Wouter Schivink, who tried to classify these CSF leaks in Neurology magazine, and he basically showed that there are three main types. There's a type 1, which is related to a dural tear or a defect that is most commonly caused by some type of bone spur or a calcified disc. And you can see here on the left side that rent in the dura causes leakage of spinal fluid, and that oftentimes will result in an epidural collection in the ventral space. Now, a type 2 leak is one that is related, and you can see here in the middle panel, when a diverticulum, meningeal diverticulum, leaks CSF, and this is oftentimes into the dorsal or dorsolateral space. These leaks we oftentimes call the wet leaks because they will cause fluid collections in the epidural space. Now, it turns out there's a third type of CSF leak, which has only been recognized recently, called the CSF venous fistula. Now, these haven't been diagnosed that often because we call it a somewhat occult leak, where we don't really see them through a conventional MRI, and they oftentimes require some type of interventional procedure. This next slide basically shows us the three different types once again, but it's to show the different, through the CT myelograms. You can see on the left side, there's that bone spur that's leading to epidural fluid collection. In the middle side, the CT myelogram reveals a diverticulum with CSF spilling into the epidural space. And then finally, on the right side, you could see the CSF venous fistula with the contrast dye communicating with the paraspinal vein here. So we did a full neuraxis MRI for the patient, and we didn't find any epidural CSF collection. So that essentially ruled out type 1 and type 2 CSF leaks. But we still knew from the high burn score that there was a high index of suspicion for some other underlying CSF leak, presumably a CSF venous fistula. So these CSF venous fistulas are relatively new pathologic entity. It was only described basically 10 years ago through Wouter Schivink and his colleagues at Sinai. And so here they reported the first 3 cases in 2014, and what they found was that there is essentially an abnormal connection between the intrathecal compartment and a spinal vein, and this connection causes continuous loss or egress of CSF out of the thecal sac, and then this leads to the spontaneous intracranial hypotension. So how are these CSF venous fistulas formed? We don't know, but it's surmised, or it's believed, that it occurs at the level of the arachnoid granulations. So we all know these arachnoid granulations primarily in the cranial compartment. They're outpouchings of the arachnoid, and they extend into here the superior sagittal sinus. You'll also see them in the transverse sinuses. And these arachnoid granulations are the point of where the CSF gets reabsorbed into the venous system. Now, interestingly, we also have these arachnoid granulations predominantly found in the thoracic and lumbar spinal region, and they're oftentimes found near the nerve root sleeve cyst. And so here in this diagram, you could see that it is possible that there may be a rupture or some type of increased flow that allows communication of the CSF to go into the spinal vein. So these type of fistulas can drain into the venous anatomy, and we, just as a recap of normal venous anatomy within a vertebral segment, there's a high degree of variability of venous drainage in general. And so oftentimes anatomists sort of break it down into three different systems. There's the external vertebral venous plexus, which includes segmental veins and lateral branches. This is one of the most common drainage patterns for these CSF venous fistulas, but there have also been other CSF venous fistulas that drain into the intervertebral venous plexus or even the basivertebral vein. So as I had mentioned, these are extremely challenging to diagnose, and it's like finding the proverbial needle in a haystack, or maybe we should say the proverbial pinhole in the fecal sac. So it oftentimes involves some type of interventional procedures. I turned over to Dr. Caton. I'm going to let him sort of review to you how he found this entity. Travis, you want to talk, and I could page through the slides. Are you there?
Sounds good. Sounds good. Can you hear me okay?
Yep.
Good. All right. Yeah. Thank you. For the background. I think, the key here is that CSF venous fistula is something that is relatively newly understood, as a pathology, and the techniques are still sort of catching up. There's been a lot of advances in the last few years. So I'll talk about them a little bit here. But I think that the key takeaway from this is that this is not something you can diagnose with cookbook imaging, where you push a button, get a study, come back with a report and diagnose it. These are MRI occult lesions, so you really have to think probabilistically about which patients to study, because it really does require an invasive procedure, at this point in time. So of the ways to look for CSF venous fistulas, the two most common are what's called digital subtraction myelography, or DSM, and CT myelography. And in both cases, those are sort of dynamic studies. In other words, they're not done where you inject contrast and let the tech post-process the images and just kind of look at them the next day or something like that. These are procedures that require a lot of planning, a lot of forethought, a lot of communication with the technologists, and a lot of sort of an art of the interpretation. There are strengths and weaknesses to the two big categories, DSM and CT myelography. A lot of it is user experience. I trained in CT myelography, so I prefer that in most cases. The trade-off is always temporal resolution versus spatial resolution, as with most imaging modalities. So why don't we go to the next slide? When you're doing imaging for CSF venous fistulas, regardless of whether it's in the angio suite or on the CT scanner, what you're trying to do is image the nerve root sleeve with contrast, as accurately and as intentionally, I would say, as you can. In order to do that, we do a decubitus position. That is to put the nerve root sleeves in a gravity-dependent position. And we also tilt the patient with a caudocranial gradient. As you can see, this is a device I think is used by the German group to achieve sort of a slope from the caudal lumbar puncture area up to the cervical levels. Ideally, you have like a 10 to 15 degree pitch there, and the dynamic comes in because what you're doing is you're imaging as that contrast tracks from the lumbar spine. And I like to say it paints the dependent nerve root sleeves all the way up through the thoracic levels to the cervical levels. And this happens quickly in a matter of seconds. So you really have to scan quickly because these CSF venous fistulas are often transient. They're often visualized only when the contrast is really dense and dependent in the site of leak, and they may fluctuate over the course of a scan. They may come and go and disappear. So proper positioning, proper timing, proper planning is really key for these studies. Okay, we'll go to the next slide.
And Travis, maybe I'll just mention that when you prepare the patient, you often tell them that sometimes it's a 2-day procedure where you'll do
Sure.
On the first day, the right side down, and then on the second day, left side down, just to let them know, because sometimes you won't find it on the first day.
It's an important point with any of these studies. When you're counseling patients, you have to give them a realistic understanding of the sensitivity of the study, which is hard. And it's really dependent on the burn score, the clinical presentation. You have to really know, is a negative study negative because there's no leak, or is it a negative study because you had an adequate technique or you were looking in the wrong location? The reason why we counsel people that they may need 2 procedures is because in order to image one side, left or right, you really get one shot, right? You get one shot of that dense contrast bolus painting the nerve root sleeves. If you reposition the patient to the other side, that contrast is going to dilute in the CSF, and you really lose that diagnostic yield. So often what people will do is plan for 2 procedures, have the patient come in for one side, one day, recover, and come back the next day and study the opposite side. So in this particular case, knowing what we knew, a high burn score, unusual sort of presentation, atypical presentation, we started with a right dynamic decubitus CT myelogram. The reason why we did the right side is just that empirically, these fistulas tend to be more prevalent on the right side than the left side. They tend to be more often at the thoracic levels than at the cervical or lumbosacral levels, although all of these have been described and are possible. So this is just probability. We wanted to get the most bang for our buck on sort of the first study. So we positioned the patient, as I showed, we showed on the last slide, in a decubitus caudocranial tilt. We did 2 additional maneuvers that I sometimes use to try to exaggerate a fistula. Those are something we call pressure augmentation of the CSF and resisted inspiration. Those are 2 sort of simple things that try to increase basically the voltage of the fistula, the gradient from CSF to vein. So if you think about it as a gradient that may be intermittent, it may have an equilibrium point. You want to stack the odds in your favor. So increasing CSF pressure, we did that in this case by injecting 8 or 9 cc's of normal saline into the CSF to try to raise the CSF pressure. We also had the patient do what's called resisted inspiration, which is basically through a sterile syringe, pretending like they were drinking a really thick smoothie and inhaling and inspiring. And what that does is drops the intrathoracic venous pressure, the central venous pressure, without affecting the CSF pressure. So those 2 maneuvers, in theory at least, create elevated CSF pressure, decreased venous pressure, therefore increase the gradient, and in theory should make the CSF fistula more visible. So this is a picture from our first pass here, the one that's annotated, which shows a CSF venous fistula at the right T8 level. So you can see contrast in a nerve root sleeve. You see a meniscus of the contrast there, which tells you the patient is decubitus, right? It's in a dependent portion of the thecal sac. And you can see it tracing out along the paraspinal vein. Now, to give you an idea, that is not the most obvious thing in the world, but that's about as big as these get. That is a big CSF venous fistula. They're often much more subtle than that. I post-processed in the other 2 images you see here with a MIP reconstruction, which I think shows the anatomy quite well, right? You can see the paraspinal vein, and you can actually see the azygous vein at the top of that figure right there, right? Yeah, perfect. So you can see that's helpful for procedure planning. You can tell that the azygous is the draining site of that fistula. And then the 3D reconstruction, I think, is helpful just to show from an anatomic perspective what this looks like. So we were lucky on our first day, we sort of found the diagnosis. And the next question was, what to do about it. So there are 3 treatment strategies for CSF venous fistulas. I think all of them are valid. All of them are useful. And there are some considerations you might use depending on what site or center you're at. I think the most conventional treatment for these is a modification of something we do for other types of CSF leak, which is patching with fibrin or blood. That is to say, placing a needle as close to the suspected leak location as you can and injecting percutaneously material to try to seal up the fistula. In some centers, that's used with pretty good success. I think from a conceptual standpoint, you're relying on anatomy to try to position your needle, and it may or may not have the durability of the other treatments. We don't know, but people who are good at it get good results. Surgical repair is, described a lot by Dr. Shavink and his group, and they have really good results as well. Basically, once the fistula is identified, they go in and ideally as minimally invasively as possibly and basically ligate the fistula surgically. That can be really useful, really effective. There are some locations where that may not be optimal. For example, the cervical or lumbar spine, where the nerve roots are more elegant. The most recent, strategy is endovascular treatment. It's described by Dr. Benjikji and his team a few years ago now at Mayo. And this really is like building off of like how we think of fistulas in the cerebrovascular side, right? Which is there's an arteriovenous connection. You can either try to plug all the arterial pedicles and seal into the vein to shut down the fistula, or 30 years ago, someone came up with the insight of, well, what if we went to the vein and plugged up the vein? We might knock out all the pedicles at once. The same concept, has been developed here for CSF venous fistulas. We can't really go into the CSF and embolize through the CSF. So Benjikji and his team found that if you figure out how to navigate the veins and get down to the side of the fistula, you can actually inject a liquid embolic, much like we would do in the, cranial dural fistulas, and try to seal the fistula retrograde from the venous side. And they've had really good results with that as well, and a pretty favorable complication profile. So we'll go next slide. After a discussion, Chan and I discussed this a lot. We discussed with the patient a lot. We decided, given that I thought the anatomy was favorable, and I could see the azygous vein very, very well, we would go with the endovascular approach. So here on the first column, you can see the myelogram images, which I use as my map to confirm the level, and reconfirm and triple confirm and quadruple confirm that we're at the right level, because we don't have any other landmark during the embolization procedure. Then what we do is basically go up and over the azygous vein and map out the spinal epidural venous drainage pattern. And doing that, you can see in the middle column with our catheter down in the azygous vein, we've selected the right T8 paraspinal vein, and you can sort of see the parallel appearance of the paraspinal vein to where the fistula showed up on the myelogram. You can even see the perinerve root venous plexus a little bit, which is hiding right under, right within the neural foramen, where these fistulas, typically occur. So we were able to navigate as close to the presumed fistula as we could. We used a balloon and onyx copolymer, and we injected that to try to fill the perinerve root venous plexus and penetrate that liquid embolic into the internal epidural venous plexus, inside the spinal canal. And then as we achieve that, we let the onyx reflux a little bit into some of the other smaller channels along the paraspinal vein. And of course, there's a little bit of reflux into the intercostal vein. This is the final result here. And the last column is an onyx cast in an axial and a coronal intraprocedural CT. And you can see it matches pretty well, what we saw on the myelogram. So, we were pretty happy with that result from a procedural standpoint. But again, unlike cranial dural fistulas, you can't do a control run, really to check to see that it's cured. So you really have to do the most you can during that procedure the first time. Okay. I'll pass back to you, Chan.
Thanks, Travis. Yeah, so after he underwent this endovascular procedure, the patient started to develop progressive improvement over a relatively short period of time. Within a week, he was starting to feel a lot better. And so we did an early follow-up MRI, and you could see here in a relatively short period of time, a significant difference in the MRI imaging. So on the left side, you could see this is the pre-embolization procedure. On the right is post-embolization. There are a variety of interesting findings. Pre-embolization, the pituitary was above the level of the planum, which is this dotted line. Post-procedure, you could see that the pituitary assumed a more anatomic position. There was decrease of pre-pontine CSF space, which clearly increased here. One of the burn measures the mammalopontine space, which was now more measurable, whereas prior it was very small. And then here you could see at the level of the foramen magnum, there is much more improved CSF space. And quite remarkably, scanning the spine in this short period of time, there was also an associated improvement in the syrinx. So, endovascular treatment of these CSF venous fistulas is still a relatively new procedure. Brzezinski, who was the first to report, gave a follow-up study reporting 40 patients, and he found that approximately 83% had significant improvement in their symptoms. There were some possible complications, which can include sort of a transient worsening of the headache, which is ascribed to a rebound intracranial hypertension. This doesn't occur that often, but is oftentimes managed medically with Diamox. Sometimes the patients also develop localized pain to where the embolization site was. That can even involve sort of like a radiculopathy. And then he also reported some evidence of onyx pulmonary emboli, but none that were any clinically significant. So treatment of these CSF venous fistulas is evolving to involve physicians in multi-disciplines, including neurologists, interventional radiologists, and neurosurgeons. And at these other hospitals throughout the country, they're starting to develop centers related to treatment of these. So now going back to our original case, could we have known a priori whether or not this was a spontaneous intracranial hypotension versus a so-called classic Chiari? And in doing so, I sort of went into the literature, and there was a recent publication by Hawk and colleagues in 2022, and they went and they looked at their series of patients, and they found that, yes, we know that in a Chiari patient, there's a small posterior cranial fossa, but the spontaneous intracranial hypotension patients usually had more profound midbrain sagging. And so some more reliable features are if you see a downsloping of the third ventricle, or you could see other evidence of midbrain sagging, such as narrowing of the mammalopontine distance or flattening of the pons. They looked at various cut-off metric measurements, and the two that were most significant was this third ventricular angle in relation to the plane of the incisura, or essentially you could look at that as downward sloping of the third ventricle, and then this PMA angle. Now, this harps back to what Mike Hurley had shown is all the different types of Chiari malformations. And, there have been other neurosurgeons, notably in the 1990s and early 2000s, who were starting to look at their Chiari series critically, and they were noticing that, yeah, there are different Chiaris that don't fall necessarily under the initial rubric of what Hans Chiari had said hundreds of years ago. So this Chiari 1.5 is an entity that Shane Tubbs and Jerry Oakes had published, and they noted that they were trying to describe Chiari 1.5 as a Chiari 1 malformation with brainstem herniation through the foramen magnum. And what they found was that these patients had a caudal descent of the obex and also flattened appearance of the mid-sagittal plane in all these patients. And interestingly, these were difficult patients to take care of because they oftentimes did not improve after surgery, and they required repeat operation for a persistent syringomyelia. So in thinking about this, I was wondering, did the original Chiari 1.5 were they actually a manifestation of spontaneous intracranial hypotension with some brain sag features? So going back to Dr. Bolognese's talk, he put up this really helpful slide. Tonsillar herniation, can occur in a different variety of settings, and the context matters for all you Bloomberg fans out there. So you have to sort of see if is there a hypotension component? Is there a cranial settling, or is it a so-called classic Chiari malformation with a small posterior cranial fossa, or as Dr. Nidich had shown us, there are some patients who have a very small foramen magnum, and that can lead to cranial constriction. So the context matters when you look at the tonsillar herniation. So in summary, this was the first demonstration of a transvenous embolization for CSF venous fistula, which resulted in an improvement in syringomyelia. Travis and a whole bunch of us are trying to put this together and get it out there as a case report. So I'm going to transition to the other part of the talk. I'm going to try to make this go quick because I know we spent a lot of time on this interesting case. This is a case of a 54-year-old gentleman. He was a tennis instructor. He came to see me after a 1-year history of progressive weakness and spasticity. Imaging shows what appeared to be a mid-thoracic syrinx with expansion. He appeared to have what we call as the scalpel sign, and so we took him to the operating room, did a thoracic laminectomy, intradural exploration. We found this arachnoid web and lysed these adhesions, and here in the far panel you could see the nice exposed cord. And he did very well after this surgery, and it was somewhat of a rare phenomenon, but what we sought to do was to try to learn more about this rare entity, and so we reached out in a collaborative effort to other members in the department to try to pool together our experience in this relatively rare condition. Special thanks to Matt Carr, who really was able to get this finally published, and then also special thanks to Tanvir, who was really helpful in the early organization of this, and of course to all the surgeons in the department who contributed cases and helped with editing the manuscript. But we just got this accepted, and so the idea was we were trying to look for as many of these dorsal arachnoid cysts and webs found at Mount Sinai, whether they were found through surgeon case logs over a 10-year period, or we also looked within the radiology PACS system, and we did a search using a variety of terms for which we may pick up these cases within our health system. After we had this retrospective review of these cases, we looked through all the charts. We excluded cases where there were ventral cord herniations or there was a syrinx without any identifiable arachnoid web. And we also excluded cases where it wasn't a focal area of arachnoiditis, more diffuse arachnoiditis was excluded. So we found originally 499 cases, and we identified within that group 127 cases that had the arachnoid web. The average age was 59. Most of them were male. We broke down the patients into three radiographic phenotypes, if you will. Type 1 patients had just spinal deformity. Type 2, as you see in the middle, is spinal deformity with a edema or myelomalacia, and then type 3 has the associated syringomyelia. In our group of 127 patients, most of the patients had 58% had spinal deformity only, but there was a significant portion of patients who had both myelomalacia and syringomyelia. Interestingly, we found that a lot of these dorsal arachnoid webs tend to cluster around the T4 distribution or the upper thoracic region. The patients, after looking through all of their charts, the two most common symptoms that they presented with was gait instability and lower extremity numbness and pain. And for those patients who were symptomatic and who had undergone surgery, essentially 32% of the total number of cases had gone for surgery. Most of them involved simple decompression. There was only 2 cases that required a fusion. Within the paper, we highlighted 2 cases. This was an interesting patient earlier on in the 10-year series, 52-year-old female patient who had bilateral lower extremity paresthesias and pain. She actually refused surgery because she felt she was quite comfortable and functional, but then was followed, and over the next 8 years, you can see that the syrinx had enlarged and she started developing worsening ascending symptoms, and she ultimately agreed to go ahead with surgery. And she had some clinical improvement, and yes, there was a decrease in the size of the syrinx, but there, of note, she did have some residual neuropathic pain. And that's oftentimes a hallmark of syringomyelia, is that it's a very painful condition. So last case, case 3, showed a 50-year-old gentleman who actually came to us from overseas. He was diagnosed, he had, interestingly, a remote history of shingles along the same dermatomal distribution of where we're seeing this syringomyelia. And overseas, they had chosen to do a lumbar laminectomy and sectioning of the filum terminale, and his symptoms never got better after that surgery, nor did his syrinx. 2 years later, he came to Sinai, and a thoracic laminectomy was done, resection of the arachnoid web, and you can see here in the post-op scan, the syrinx has much improvement. He had improvement in the pain that was involving his thoracic area, but his lower extremity symptoms continued to bother him. And so he did have some residual pain. So I think the reason why our paper was somewhat compelling was that we were able to include a relatively large series of path specimens that were sent. We had 27 specimens. All of the cases had fibroconnective tissue, but interestingly, about a quarter of the cases had some degree of either bone formation, calcification, or hyalinization, and somewhat in contradiction to the rest of the literature, we did see some signs of evidence of inflammation, and it's unclear if this can speak to different pathophysiologic mechanisms of the formation of these webs. We looked back, and some of the early anatomic reports had characterized this septum posticum, which is a arachnoid membrane that partitions the dorsal part of the subarachnoid space. And some people theorize that this may be part of why these arachnoid webs or cysts form. So in summary, over a 10-year period at our institution, most of the patients didn't need surgery, but those that had syrinx or myelomalacia, if left untreated, they would deteriorate. Symptomatic patients did very well clinically after surgery, and there was relatively low surgical morbidity. Interestingly, a quarter of the patients had seen some calcification or hyalinization. This suggests that perhaps one of the mechanisms of these formations may be an arachnoiditis ossificans. And then this is just a summary for the whole talk. Syringomyelia is not a disease entity in and of itself, but it's a pathologic condition common to a variety of different disorders. The syrinx forms because of a blockage at the subarachnoid space or spinal tethering or damage to the spinal parenchyma. And surgery can be a good option in select cases. Successful surgical treatment targets the appropriate mechanism of syrinx development. That's about it.
Thank you so much, Chan and Travis. Do we have any comments, questions? So I have one. I see a handful of patients in my practice who have these really convincing leak symptoms. I was just texting Travis about one of them, but and they really have no correlate on their imaging. Like they don't even by the Baird score, like they have a pretty low score. And I always wonder if there's something that we're just not capturing in these patients because their symptoms are very real and they frequently get dismissed by other providers as, frankly, crazy or just psychologically disturbed in some way, or we're having some form of PTSD from a trauma. What's your take on how to approach these patients and counsel them, work them up further if you think it's appropriate?
Yeah, it's definitely, I was at the spinal radiology meeting last week and off the podium talking to a lot of these people from the major CSF leak centers. I think this is the biggest challenge. The patients who don't have the high burn score, because there's a question, it's a stopping problem, like in computer science. Like, when do you say enough is enough with the diagnosis? There are definitely patients, I can't quote a number, but in the large volume centers who are low or normal burn score, who are found to have like a fistula and who improve after treatment of it. It's all probability, but there's always going to be those minority cases, where they don't have the glaring brain imaging signs. I think that, if you have someone who has had, a thorough workup is really characteristic in their symptoms, but hasn't had anything, come up positive, I think it's very reasonable with the appropriate counseling to do, something like a dynamic myelogram, with the, caveat that, if it's negative and they have a low burn score, you have to say, it might truly be negative, right? It might be something else. It just takes a lot more counseling. On the flip side, right, people with a really high burn score where you don't find a leak, it's a little bit of an easier decision because you have to keep looking. Like, something has to explain those brain imaging findings. So I think, to summarize, I think patients like that, are definitely shouldn't be ignored and are definitely important patients to consider for the invasive imaging. You just have to, I think, have honest discussions about the probabilities, and what we think is the diagnostic accuracy of that test.
I think that's a great way to think about it. Thank you. Do we have any other questions or comments
Yes.
before we adjourn?
I have a question for Travis and Chan. Given that the CSF venous fistulas can be treated effectively with MIS surgery, and given that the endovascular treatment is associated with significant radiation exposure, so that there's already like a disadvantage with the endovascular approach, what is the perceived advantage of doing that treatment with the endovascular approach versus doing like throwing a tube and ligating the draining vein?
So, Khan, I think that's a great question, and I think the long-term answer to your question will be whether or not the endovascular is a durable procedure. Can we potentially get recanalization, and then how effective was the initial embolization? Because you can, some of these patients actually get other leaks in multiple locations. And so there have been reports where they'll find several venous fistulas. And in that setting, it may be better to do endovascular because there's less dissection. But I think the current state of knowledge is that open surgery has the longest long-term durable improvement. And there are various ways. Some surgeons clip just the vein, others will ligate in the thoracic area, in the so-called non-eloquent region. Some will even sacrifice the root. And so I think when you're dealing with more eloquent nerve roots, then endovascular may be a better option too. So your question is excellent. I mean, it's going to depend on the particular case.
Yeah, I agree. I would say that, if you ask, like they did in a panel that I was watching last week, these Shavink and Kranz and all of these people, there really is no definitive answer. I think this is such an evolving paradigm. I think the surgical approach for certain anatomy, certain fistula locations, seems to work really well. It's also not without complications. It is more invasive. So I think patients, will often err towards the endovascular treatment from just the invasiveness standpoint, but that may not always be the right option for them. And there are downsides to that as well, right? If you fill up a bunch of veins with onyx, but you're unsuccessful, then you have a much harder time re-diagnosing, a persistent or recurrent leak because you have embolic material blocking, your view if you were to repeat a myelogram. So there definitely are, downsides to the endovascular approach. I think the radiation dose is probably one of the lesser ones. I think that, in the big picture, that accumulated radiation dose, if you can diagnose it and treat it, then that dose is tolerable. Many of these patients will have had, several, if not dozens, of prior radiation, procedures in attempted diagnosis before. So, I think that's maybe a smaller consideration. It's more about the question of durability, which we don't know.
All right. Well, thank you, everyone. It's a really thoughtful discussion. Appreciate the presentations today, and we'll see you all next week.
Thanks, Peter.